Okay, we might get started. Welcome to the third public lecture in the Australia Centre's Critical Public Conversations lecture series. My name's Dr. Liz Strakosch. I'm filling in as chair today. I'm a lecturer in politics and policy at the University of Melbourne and a fellow of the Australia Centre. And I am also a director of the Institute for Collaborative Race Research in Meanjin, which is what you can see behind me here. But to welcome us to the country where the Australia Centre and this webinar is hosted, I'd like to ask Ani Diane Kerr to speak. Thank you. Thank you so much for that incredibly warm welcome, Ani Di, and for starting to connect us to the work of this speaker and to linking together those questions of health and well-being, Indigenous sovereignty, and caring for country, especially in conditions of climate crisis, which is part of the bigger theme for the Australia Centre in this seminar series today. The theme is climate, country, colonialism. And so we're looking at the relationship between colonialism and climate change and well-being in the broadest sense. And the series seeks to highlight the settler states' incapacity to manage the ecology of this continent and to highlight the way in which First Nations care for and fight for on the front lines country, and how that care for country is inextricably bound with questions of sovereignty. So in that context, we're really privileged to have with us our speaker for today, Dr. Ngaree Blow. She's a Quandamooka, Gureng and Yorta Yorta woman, currently completing her advanced training as a public health physician. She works as the Director of First Nations Health for Medical Education at the University of Melbourne, as well as dedicating part of her time to consulting on public health projects. Ngaree has worked in various medical and public health roles, including as lead medical officer for the COVID-19 outbreak response in 2020 and the COVID-19 vaccination program in 2022 with the Department of Health Victoria. She also established the First Nations-led and run music health festivals, It's a Mob Thing, across Victoria in 2022. And I think you said before, Ngaree, that you're also playing in the treaty football tournament this weekend. So multi-skilled. Dr. Blow was most recently recognised for her work in 2022 when awarded the MDHS Award for Excellence in Indigenous Health Engagement, as well as the Australasian Faculty of Public Health Medicine Victorian Jerry Murphy Prize in 2022, and was named one of 2019 Australian Financial Review's 100 Women of Influence. So if I've embarrassed you enough, Ngaree, I will pass over to you. But before I do, I'd just like to remind everyone in the audience that you can submit your questions at any time. So as they come up for you during the discussion, please put them through with the Q&A function, and then we'll be able to read these, and Ngaree will be able to answer some of them in the Q&A session after her presentation. So thanks very much, Ngaree, and over to you.
Ani Di's life and to have grown up on Wurundjeri country. And so I just want to pay my deepest respects to Ani Di and all the elders of Wurundjeri and the extended Kulin Nation for which I've grown up on. I've grown up on both Bunurong and Wurundjeri lands, as well as on my mother's country and on Yorta Yorta country and Shepparton. So I do need to acknowledge those countries and acknowledge those peoples as well. And I'm also going to just introduce myself in my father's language, and I will explain a bit as to why I'm doing that in a second. Bunjis, Naja, essentially what I did there was just acknowledge in my father's language, which is the Jundai language of Minjerribah, also known as Torranduri, both traditional names for what is known as North Stradbroke Island. It's an island just off the coast of Brisbane or Meanjin, and there's also an island just below it, Murrugumpin or Moreton Island. Those islands together are made up of three nations, Nunakul, Ngugi and Gurrumpul, and together we are the Quandamooka people. And I'm actually sitting on Quandamooka country right now, and that's really special because I'm not often given the privilege of being able to sit on my own country, and to, I guess, speak in language and acknowledge that country. And I also did acknowledge my mother's country as well, and acknowledge the Wurru Wurru and Bangarang people of around the Shepherd, Echuca, and Wangaratta area. And I acknowledge that as the primary part of my protocol, because that is where my knowledge is passed down from. That is where I am coming from. That is the perspective and the lens that I am bringing. But I'm also very much bringing what I've been taught as well from Wurundjeri elders and community. And that is also the basis of what I'm going to be speaking about today. So I'm just going to share my screen so that I can share some visuals while I'm talking. So give me one moment to do that. Hold on 1 second. All right, I just want to double check that that's coming through, Liz.
Yep, definitely. Thanks.
Great. So as Liz mentioned, I work as a medical professional, as a doctor in the space of public health. I'm a registrar, a trainee with the AFM College, which is part of the Royal Australasian College of Physicians. I'm also an academic and director of the Wurru Wurru Health Unit, which is in the Department of Medical Education in the Melbourne Medical School at the University of Melbourne. And so I will be speaking to how we've embedded country and Indigenous ways into health teaching with the Wurru Wurru health model. And I'll explain a bit more about what that means. It's really nice because this feels like just a continuation of the last time I had the chance to actually share this space with Ani Dai and with Stacey Piper Nicholson as well, when we did a session in March during International Women's Day. So I guess this will be kind of extending on some of those things that I spoke about last time. To explain though, the Wurru Wurru Health Unit is an all Indigenous team that is based at the university. We're all First Nations Australian and one Indigenous person from Zimbabwe. And our team is comprised of academics, researchers, and also professional staff from multiple nations across the First Nations. And we have our own collective and our own space within the medical school because we needed to create spaces to bring in multiple voices and lenses, because as we know, First Nations people is not a homogenous group of peoples. We are multiple nations and therefore multiple cultures. However, we are based on Wurundjeri country because Melbourne University sits on the Parkville campus in Carlton. And to acknowledge that, we wanted to respectfully use Wurrung language in our name. And we spoke to community a bit about, I guess, the concepts around our health. And there was a particular story that we talked about around the 6 layers of country. And Wurru Wurru represents sky country in that. And it also represents the kingfisher bird. So we've represented that in our logo. And I guess the reason behind naming the health unit to do with the 6 layers of country is part of the story, but also because of the way that we look at health and we look at it, I guess, holistically and I guess from that sky view as well, to encompass all layers of country. And I'll explain a bit more of what I mean when I talk about the model. So the biggest challenge when first working in this space is I actually had personal experience of being a medical student at the university and understanding that health was taught very much in a biomedical approach. So treatment of disease and maybe a little bit around the biopsychosocial aspects of healthcare, but really not in the way that I had grown up learning about health and well-being. I had the privilege of learning traditional medicines from my father, which had been passed down from his grandfather and grandmother as well. So I guess the view of health for me was quite different to what I was being taught as a medical student. And actually, I guess the concepts of health are quite similar across a lot of the First Nations that make up Aboriginal and Torres Strait Islander people. And this has been recognised through the National Aboriginal Health Strategy, which was brought out in 1989 and also used quite significantly across a lot of definitions of Aboriginal health. And this definition that Nacho put together was talking about health being more than just the physical well-being, but also the social well-being, the emotional well-being, and specifically the cultural well-being. And also importantly, that is the whole community rather than just an individual, thereby bringing health of the whole community together. So this is where we started when we thought about how we could decolonize some of this health curriculum for medical students, but also for the broader health profession students. We also looked quite a lot at the, I guess, the research that was out there in the literature. This might be familiar to some people who have worked in the space of Aboriginal health, but this is a really important model that was brought out by Graham G, Pat Dudgeon, Clinton Schultz, and a few others that worked on this in 2014, looking at social and emotional well-being of Aboriginal and Torres Strait Islander people. And what I really like about this model is that it really looks at not just, I guess, this social determinants, which often get talked about a lot when people like government or other institutions talk about health and well-being. They talk really about economic status, they talk about housing, they talk about education, which are all within those social determinants realm, but they don't also really focus or hone in on the historical determinant, which is where I guess the decolonizing part comes in, because historically there's two aspects of it. There's one that historically before colonization is not recognized very well. And then during colonization, the policies that were really detrimental to communities are not actively recognized as well. And so those historical determinants really have a huge impact on health and well-being. And then on top of that are the political determinants and those government policies and things that continue to impact our people and our communities. But overall, the cultural determinants are really significant and unique because we are over 250 nations. We are also over 250 different cultures, and that we are continually being looked at as one group. What I like about our communities is how we describe and look at health. And I've just put a couple of examples on that. From Wurru Wurru language, my mother's people, colonial is a word that is used to describe good, to describe whole, to describe beautiful, to describe essentially healthy. So that word in itself has multiple meanings that really encompass health and well-being. And then I know in Wurru Wurru language, Ngaree is also used quite often, or Ngaree Nun, around healing. And again, this word isn't just healing or health, it's also about the connection to mind, body, and spirit. And when we look at somewhere like Central Australia, there's a lot of work that is being done with Ngaree, the traditional or spiritual healers of community. And so all of these concepts of health, although different words and different meanings, none of them mean absence of disease. And that is something where we need to shift the definition when we're talking about disease or healthcare in this country. When we look at First Nations in practice, if you look at any curriculum design, there's usually a set of accreditation standards. If I'm thinking about medical students as an example, the Australian Medical Council has a bunch of accreditation standards, and now they've all been set around cultural safety. There's also a bunch of curriculum frameworks, but it's really dependent on the institution on how this is taught and how it's done. The other issue with First Nations health curriculum and research and education is that there's minimal support around it. There's the leaders in Indigenous medical education. There's also national bodies like Lowitja and AIDA, but really there's also low representation also of Indigenous academics who can also teach into this space. So what this means is that teaching or curriculum is often isolated rather than integrated. So there's usually a one-off subject in a nursing course or a one-off subject in a medical course that is taught. Usually it's around statistics and not much information around the underlying causes of disease. It's very clear that there are health disparities, but not particularly the value of the teaching is dependent on the institution, how much they're going to put into this. And there's often a lack of role modeling of this holistic approach that I'm for. And people from multiple levels of an institution to be able to, I guess, show the value of this teaching. And there's also unlearning that's required as well. And that's part of the decolonizing framework and process. So when looking at decolonizing curriculum and ways to embed Indigenous knowledges into health teaching, I utilised, I guess, my connections with Indigenous peoples from around the world to be able to discuss and yarn about different strategies around teaching this. And we looked at a lot of Canadian resources, which were really specific to First Nations, and also went across to Aotearoa in Christchurch at the university there. There is an academic, Suze Patamo, who did an amazing PhD work in creating the Haura Māori process around utilising a model of healthcare that embedded Māori ways of knowing. And when you looked at other things over in the States, you could also see the different ways that social and cultural determinants of health have been brought in. What is not surprising is that despite social determinants of health, so whether that be your social status, your economic status, your employment status, your education status, Aboriginal and Torres Strait Islander people still have the largest disparities, which means that there's something very much linked to race and racism. And often racism is excluded from a lot of these teaching models. So we've taken a really big focus on teaching racism, but also teaching specifically about self and understanding your own biases and attitudes towards communities as well. This was by no means a short process. This is a process that involved multiple conversations with community. It also involved multiple stages. This is just a overall representation of how we did the research in this space of creating the Wurru Wurru social determinants of health model. Throughout all these stages, though, we went back to community. It was really an iterative process and had those yarns, and some of them were formalized and recorded and analysed, and some of them were actually just informal discussions or just being at community events and hearing from community about what the priorities for community are. And throughout this, we went back and we changed the model and then talked to community and then changed it again. So this is something that's also a living and breathing model that we also are open to continuing to change and adapt based on community need. So I wanted to, rather than talk to it directly, I wanted to show a short video that I have here of me talking with Stacey Piper about this process of designing the model. So I'll try and share this now. Please send something in the chat if you can't hear the sound.
Biladun yang wangat, naranik Stacey, Waranjeri Willamik, Waranjeri Balakut, Ba Jajawarang, Ba Nura Ilamwarang. Mundanai Murup Kalada Bidadang, Mundanai Liwik Bulok Nugalik, Mundanai Willambik, and Mundanai Kirip. In my language, the language of my family, the Wurundjeri people. I introduced myself. My name is Stacey, and I am a proud Wurundjeri, Dja Dja Wurrung and Ngaree Wurrung woman.
I love hearing the Wurru Wurru language, so thank you for sharing with us. So to introduce myself, my name's Ngaree. I'm the Director of First Nations Health at the University of Melbourne, and I'm also a public health physician trainee. And so I'm here today. I'm a proud Quandamooka and Gureng Gureng woman on my father's side and proud Yorta Yorta woman on my mother's side. And so I've grown up on this country, on Wurundjeri country, so that's why it's really special that I'm here with you here today, and we're able to talk about some of the work we've been doing together, which is the social determinants of health model. And so when we wanted to teach the social determinants of health model, there's lots of different structures of how that is taught, but what was missing was really that perspective of our peoples, of the First Nations people, particularly the effects of colonisation and the effects of things that really have affected our people, like institutionalised racism in this country. And so we wanted to teach that, but also bring in concepts of Wurundjeri country and language and culture and knowledge. We've got 3 versions. One is an overview of social determinants of health, which we call now the 6 layers model. And then we also have the river model, and then we have the flow chart.
When you showed me this model, it was really obvious that there were alignments with the values that we have with the 6 layers and what you were talking about. We have the Tharangolk, which is the country above the clouds. That's Bunjul's home, so Bunjul, our creator. And then we have the Wurru Wurru Bik, which is the sky country. And then we have the Murrumut Bik, the wind and the air country. The Banyabik, which is the water country. The Bik Dewey, which is on country, and that's where we conduct our business. And then the below country, which is, the roots of the trees and underwater rivers, the soil.
I think it was really great because we kind of had that conversation about how that would fit in with the layers that we teach students about social determinants of health. And so when you talk about below country, really we thought that would fit really well when we're talking about the biophysical aspects of health, so talking more about what's going on in the body, below the surface, which is kind of where we put that section.
I think this is why First Nations knowledges are so important, because that's what it's based on. It's based not just country, but it's based on our bodies. And our bodies reflect country, so if country's not well, we're not well. The soil is a really significant life force. It sustains the planet. It's full of incredible nutrients, and when we're destroying country, we're destroying the biodiversity that lies within that soil.
And then when we went to the individual level, and that's where it really sat well with being on country. And then I suppose the next level is when we start talking about the social determinants that affect us at a societal level. So thinking about, the housing and education and things like that. So it's the things that surround us that affect us, which is kind of how you spoke about water country being around us all the time.
Yeah, and it's a life force. When we acknowledge the Birrarung is like, the veins of country, and the water flowing through is, the life force.
And then we went on to the systemic level, which is kind of all those things that you can't really see, the institutions that affect us, the hospital systems, the education systems, the justice system, which has a huge effect on health, but it's not always that obvious because it's at a systems level. And then above that, we've represented sky country and then country of ancestors as well.
Yeah. We talk about it in a way where even the trees, especially on Wurundjeri country, touch the sky, because it's something that we're really proud of here, and we like to protect that part of country. The trees touch the sky, and that's where Bunjul and Wah watch over us in the physical, and the stars are all up in the sky. And the Tharangolk is again that invisible space that people might refer in other cultures as the dreaming, but that's where our ancestors are, that's where our loved ones are, and that's where Bunjul is not so much in the physical.
I really wanted to find a way that we could bring Indigenous knowledges into something that really the teaching around medicine and around health in general has been very westernised, and so it's been hard to bring in those Indigenous knowledges. So to be able to do that with these 6 layers of country, I think was really beautiful, and I'm really glad we got to work together on it.
Biladum Yang Wangat, Naranik Stacey.
I can see if you're reacting, so obviously the video worked. That's great. I hope that gives you a little bit more of an understanding of how we combined or incorporated Wurundjeri knowledges into this model. And the reason that we did it in this way is that the main aims of the Wurru Wurru Health Unit and really just all the teaching towards health for First Nations people is about working with reciprocity. So really that value of two-way knowledges and that exchange where both benefit rather than, for example, the university taking Indigenous knowledges and just keeping it for their own. So there was also a discussion around ownership around that knowledge as well. We work alongside First Nations people, so we're not working on behalf of, and we also want to be working collaboratively to achieve health advancement so that there are improvements in healthcare that are done in a way that is together. So the model there, we've also represented in the logo above the kingfisher bird. There were other versions that were mentioned. So there's the 6 layers of country, which has also been adapted into this river style model. And that was bringing in the concepts of public health. For those of you who have done a Masters of Public Health or very aware of public health, there's this concept of upstream and downstream factors. And those downstream factors tend to be the ones that we see at the end of a health journey. So the outcomes, whether you're well or sick, and whether or not your outcomes in a healthcare setting. And the upstream factors are kind of those things all the way upstream that have kind of all combined to get you to that point in your health journey. And we actually wanted to physically represent country here. So rather than it just being a stream, it's actually the Birrarung, so the Yarra River that's represented there. And there's also the totems of the Wurundjeri people also represented there. So we've got Bunjil, Wa, and also Balian the bat as well. And often there is this concept of social determinants that are usually negative or things that, I guess, prevent you from having good health outcomes. But often there's social determinants that are really positive that often don't get talked about in public health theory and understanding. And the way of representing that is having that discussion around country again, which is when we talked about the currents and the undercurrents of the river system. And so here we wanted to represent the currents on the left side of that river model as being the things that push you forward towards good health. And so we've got examples on the left side of positive social determinants, and then undercurrents maybe holding you back. And so on the right side of that model, we have examples of barriers of social determinants or negative social determinants of health. What we also realized is that med students and most students actually love flowcharts. And so we also designed it in a flowchart model that could be used when discussing cases and talking about patient-specific scenarios. And this was a good way to bring the environment in again and bring this to life. So you can see there's the wind, which is kind of meant to be behind the model there to show that there can be things that can have a huge effect or can have minimal effects, and it really depends on the patient's situation and the current, I guess, individual circumstances of a patient. And when talking about cases, and you'll see there in the systemic row there's a bit around climate and environment, and we really wanted to highlight climate and environment because this isn't something that is directly considered when you've got a sick patient in front of you, but we wanted students to have really good understanding of all of the levels that can affect patients when they're coming to you. So it's not just about the asthma attack that's in front of you, but it's also about what's happening in the environment. You might remember that there was a big thunderstorm that caused quite a spike in asthma in Melbourne a few years ago. That was something that has actually been termed as thunderstorm asthma. So there are direct effects with climate that often get missed. We don't really talk about the effects of fires and floods when it comes to health and well-being. We talk about it in terms of losing assets, in terms of being displaced, in terms of not being able to access health at the time. But there's also a lot of physical health outcomes around smoke inhalation with fire, around infections that are caused around dampness and wet areas with floods. And so these are the types of things that not only get missed, but also don't get linked back to Indigenous ways, because we know that traditional practices of fire burning can have huge impacts on avoiding fires and also understanding circumstances around environment to avoid floods as well. So this model, we wanted it to be embedded and integrated across the whole curriculum. So that's what we've done. We put it in tutorials, in e-learning structures, in lectures, in clinical skills. And we've also made sure that it's been assessed as well. And on top of this, we try to build it across the 4 years of the course. So we start with cultural awareness concepts, because we know that we have international students and also Australian students that just don't have any understanding of First Nations people, who we are and why it's important to talk about when we discuss health. We then build on that by looking at cultural safety and the concepts around cultural safety being dictated by the person receiving care. And in third year, we go into cultural humility. This is a concept that came out of First Nations Canada. And this concept is around understanding that despite having understanding of Indigenous cultures, it's always going to be a learning journey for yourself and also for your communities as well, if you are First Nations. And so that understanding and concept around cultural humility and being aware that you can make mistakes and that's okay. And then finally, towards the end of the course, we look at advocacy and leadership in this space, because we know that doctors in particular have a lot of power in terms of advocacy beyond, I guess, the clinic and into society as well. What happened with integration of this is there was a lot of expectation that this would come directly from our unit, because a lot of non-Indigenous tutors felt they lacked confidence in teaching this because it wasn't something that they had been taught, or as non-Indigenous people, they didn't feel comfortable in teaching a lot of this content. So this is where we took a co-teaching approach. So we brought in, we have about 20 casual First Nation tutors on our team, and they're from multiple different backgrounds. So not just multiple First Nations backgrounds, but also professional backgrounds. And we've brought them in to work with the clinical tutors in the tutorials and also in some of the sort of cultural immersion activities as well. And this isn't a new concept. So there has been other universities and other schooling systems or education systems that have utilised First Nations and non-First Nations tutors. And there's quite a bit of literature out there about this. So we've looked into some of that. And what we've found from this co-teaching approach is that students really value it. They value that there's a First Nations voice, and they think that's so important. And they value also seeing that relationship in teaching. There's also new concepts and worldviews or perspectives that would have never been considered beforehand. And so that's what's brought in with this co-teaching model. The skills that have been really noted as improved around teaching with a co-teaching model is that communication has been improved quite a lot, and this understanding of respect and safety and quality of care, which of course, if you're thinking of a really good doctor or a really good health professional in your life, you obviously want them to be really good at communication, safety, quality, and respect. So this is particularly highly valued by students, and it's been a really successful way of progressing in cultural awareness and communication skills. And so with this co-teaching approach and using the social determinants of health Wurru Wurru health model, we've been able to integrate this together in the teaching. We've also expanded the approach by making sure that we have really good partnerships with local-based Aboriginal and Torres Strait Islander organisations. The peak body in Victoria is BATCHO, and so we work with BATCHO quite a bit and get a lot of advice around engaging with Aboriginal community-controlled services and clinics. We obviously work with the local Indigenous institution of Murrabbarak at the university, and then we've also work with institutions that may not necessarily be health specific, like the Melbourne Museum, but have a lot of knowledge that can be shared, that can be related to health and well-being. Because as Ani Dai said right at the beginning, health and well-being of Indigenous communities is much more than just accessing health or going to a health centre. It can be a whole bunch of different factors. We're also associated with some of the national bodies like the Australian Indigenous Doctors Association. And one of the aims also of the co-teaching model is to have visibility, to see First Nations people as doctors, to see First Nations people as academics in the university space, to see First Nations people from multiple professional backgrounds being involved in this teaching and also in the research that's being done. And this is because when we look at representation in the health sector, we have very limited numbers of First Nations professionals. And if you just take one of those professions of medicine, you can see here currently there's under 500 Aboriginal and Torres Strait Islander medical doctors in the country. And if we were to just reach population parity of 3% of the doctor cohort, we'd need over 3,000 more. So there's a long way to go if it's going to be our communities as being looked after by only Aboriginal and Torres Strait Islander doctors, which is why there's a need for non-Indigenous people to have a really clear understanding of our health and well-being and the concepts around that. The other really positive thing about this change is since we've introduced the model and the co-teaching approach, we've seen a massive increase of Aboriginal and Torres Strait Islander medical students join the program. So I do think that that visibility is coming out in the students' enrolment process, but I haven't done the proper research to say that for sure just yet. So finally, with the next steps, we've got quite a few different research pieces underway. We're still being, the paper we've written up about this model is still being reviewed, so it will be coming out and being published soon. We are also starting to talk to other communities about making different localized versions in different communities. So one of those is potentially working with Yorta Yorta community. We've had some initial discussions about maybe adapting this model to be Yorta Yorta specific in Victoria. And I would love to see these types of models adapted for communities across the First Nations that are really representative of the health priorities of those nations and the Indigenous knowledges of those countries. And so that's kind of where I see this going. So that's all from me. I'm really happy to be contacted. We have a First Nations Health MD University email. Also, we're on Twitter. I think I need to change that. I think it's now the Wurru Wurru Health unit on Twitter. But I'm really happy to continue the discussion and answer any questions as well.
Thank you so much, Ngaree. That was a wonderful and really inspiring presentation that walked us through this model you've developed for health. And in doing it, you made so many links with the bigger theme of the seminar series, you know, looking at how it is that care for country and the physical environment shape individual health within the body. So quite a few people have made comments in the chat, just wanting to let you know that they were really inspired by this model. And one question that came up in a few different ways was how far this model can travel. So you did answer that a little bit at the end of your presentation. How would it be adapted? Is it appropriate to be adapted for other First Nations? And then someone was asking, well, in education or in other kind of settings, how do you see this, the potential?
Yeah, as I mentioned, Liz, I would love to see this adapted for communities across the nations. You know, we've really used the foundation of the social determinants of health, which is very much a public health concept that's been written about many times, starting with Sir Michael Marmot, and you know, David Williams has a model, and there's quite a few different approaches around social determinants. Then we've also incorporated the Graham G social emotional wellbeing, and we've essentially combined those with local knowledges to create this. And we would love to see that kind of approach being done, but also acknowledge that this was over 3 or 4 years, these consultations and community development. So this isn't a quick process, and I don't think you can just take the model and insert it into another community. I think there has to be a really solid approach towards having those conversations with community. Needs to be led by Indigenous voices. It needs to ensure that it's been done collaboratively. It can't be, I suppose, just told to communities on how they should do it. There might be a totally different version that comes out that, yeah, maybe conceptualized in so many different ways. But I think the concepts around it and just being able to embed Indigenous knowledges into health teaching would be great to see that being done with a localized approach.
Yes, thanks very much. And this is an extension, I suppose, of that question, and very much an open question, which is, how do you see this in relation to these broader, as you said, quite violent health systems that exist today, as a best practice model of care, a First Nations way of caring for health, as Dr. Mary Graham would say, as more fully human ways of caring for people and less dehumanizing? Do you imagine that this could change practice in the broader health system, or is that not appropriate?
Yeah, it's a big question. I'm really glad that got brought up. I do want to acknowledge that a lot of healthcare systems are really violent towards First Nations people, and we've seen that over the years. We've seen the way that hospitals, you know, didn't allow people from my grandparents' generation to actually go into a hospital and give birth. And there's many stories around giving birth on the veranda of a hospital and not having physical access. And now there's also lots of stories around still not having access, even if it is physical, but because of the barriers around racism and access to healthcare facilities that are culturally safe. These violent systems continue to affect the outcomes of our people. So I want to thank that person for acknowledging that. I don't think this model is going to cure everything or you know, shift all of the statistics around First Nations health, but I do think this model, from the evaluations we've done with students, has really got students to reflect more on their positionality and their impacts, not just on the patient directly, but also on the systems around them. And that is part of the reason why we scaffold this teaching as well, to kind of end with that advocacy leadership, because we want these students to actively have a voice in advocating for and changing some of these systems, because systems, although they are bigger than an individual can have a huge impact on a system. So that is kind of our focus of using this model and continuing to have students, I guess, reflect on their role in this model. And, you know, and And of course, I acknowledge this model is mostly directed at non-Indigenous students, but our First Nations students really appreciate it as well, because there's representation of culture in that. And there's also not an expectation that those students have to teach the content, because there's actually something there. And I know that that's something that I experienced as a student, where they would look to me as an Indigenous student and ask me to solve all the problems of First Nations health. And so that's also another aim of this model, is to also support those students to just be able to learn and not have to teach.
Thanks very much. We do have a couple more questions and about 5 more minutes, if that's okay. One question was about the difficulties in incorporating or translating this model, in trying to connect it with the ways of thinking and with the kind of institutional practices that are currently dominate medical education and public health.
Yeah. You know, essentially we are looking at round models of healthcare for Indigenous ways into square boxes of westernized institutional knowledge. And so there's always going to be a situation where it's quite hard to fit that circle into that square, or vice versa. But I do think that even the institutions that have you know, brought out these medical degrees and these health profession education are starting to, I guess, value and acknowledge First Nations and Indigenous knowledges. And I've seen that change over the last few years, just in the fact that First Nations health is a priority for all schools to teach now, and it's part of accreditation standards, and it's starting to be more valued in the system. And I also see it in the way that, you know, no longer is the medical teaching this really biophysical, you know, I treat this illness with this medication, but it's now starting to look at health and well-being more holistically. And although a lot of Western institutions try and put their own labels on that, the biopsychosocial model, the whatever they want to put their words on it, but actually it's actually bringing back Indigenous knowledges into that teaching. So I can see a shift in it, and I think that is also because there are more Indigenous voices involved. There are, I guess, more understanding, awareness, and respect for the culture. But of course, there's always going to be difficulty trying to, I guess, bring them both together. But I think that if there's more of an appreciation that these can be collaboratively used together rather than as an add-on or a separate piece of teaching, then I think that we can actually start to see a big shifts in education and teaching.
Well, thanks, Ngaree. That might actually be a great place to finish the Q&A and let you off the hook with kind of some of the successes and changes that you've seen as the result of this model. And you also talked about the great news of more enrolments and the way you're seeing shifts in people's approach and ways of thinking. So I'd like to ask everyone to join me in saying a huge thank you to Dr. Ngaree Blow for sharing this model with us. We really appreciate it. And you can see there from people's reactions. I would just like to let everyone know we had a bunch of questions about whether it would be possible to see the slides just because we had a kind of low quality internet connection. Some of the slides were a bit hard to see. We'll talk to Ngaree later about whether it's appropriate to share that or if there are other places to find more information if you're interested, and we'll share that with you via email after this session. So just before we go, I would like to give you some quick reminders about the next webinars coming up, and the next one is on Wednesday, the 2nd of August. We're really excited to be joined by Indigenous writer, filmmaker and musician Victor Stephenson, whose presentation is titled What the Land Remembers Before Colonisation. And much of his work over the past 30 years has been based on the arts and reviving traditional knowledge for community and environmental challenges. So another way of connecting to this bigger theme of country, colonialism, connection, and climate. So thank you very much to everyone for joining. Thank you again to Auntie Di for welcoming us to country. And thanks most of all to you, Ngaree.
Thanks, everyone.